Welcome to Global Development Interrupted. I am Leah Petit. And if you've ever wondered what global assistance did for the world and for the United States, then you are in the right place. Today, we're going to be talking to Kent Klindera, who was, by all means, a local celebrity in the Office of HIV and AIDS at USAID. And he served as a senior technical advisor for key populations. In this episode, we're going to learn what a key population is and what Kent was doing in the 1980s in Thailand. So let's go meet Kent. Hi, Kent. Welcome to Global Development Interrupted.
Hi, Leah. It's great to be here.
So let's just start. Where are you calling from?
Sure. I live in Brooklyn, New York, and have lived here for about 15 years now.
And what was the title that you held before USAID was dismantled?
Yes, I was a senior technical advisor for key populations in the Office of HIV/AIDS.
And can you just tell us a little bit about what a key population is?
Sure. Yeah. So key populations are populations because of behavioral, biological, but also structural, sort of the climate, put them at higher risk for HIV/AIDS. So those folks include sex workers, men who have sex with men, transgender people, people who inject drugs, and prisoners or people in confined settings.
So some of the most vulnerable populations.
Exactly.
All right. But before we get into what you did at USAID, we are going to ask the fun fact question. What was your go-to fun fact?
I had many.
Sure you did.
Today I'll use, it was kind of a fun one, but I was actually the first ever HIV volunteer in Peace Corps. So I got started doing this work in Peace Corps. This was 1988, and I was living in Thailand, and they had a beginning of an epidemic there.
And Thailand has quite a story with HIV. They're one of the success stories as well.
Somewhat. It was amazing to start my career there because they came up with this idea that it's not just the Ministry of Health that should be responding. It's intersectoral. It's lots of different government offices that need to be part of a response. And they really focused on transmission. And that time it was sex workers, and came up with pretty interesting models to sort of help enforce condom use with sex workers, mostly with the people who were purchasing sex. But it really, you saw a big turnaround and in decline in infection. It was very impressive.
And so HIV was sort of exploded on the scene while you were in Peace Corps. What was that like, seeing the epidemic being discovered in the real time?
Yeah, it was really challenging. Yeah, the main thing being you really had nothing to help people with, right? So testing, by then had a test, right? I think the first test was in 83, right? So this is 88, so it's 5 years later. And you would give people results and basically say, take care of yourself, right? You had AZT came on, but it was not very effective.
And AZT was the first treatment for HIV.
Exactly. Yeah. It was 2 years in a Peace Corps site doing forestry work. And then I transitioned to work in a communicable disease control office up in the north, up in Chiang Mai. And my first day in the office, my office was focused on male sex workers. But my first day, they were giving results back to these young men. We're all in one big office, one big room. And my one coworker's in the corner giving results. And she's telling people, you're positive, which means you're okay. Just don't have sex with anyone anymore. Just stop having sex because that will help keep you healthy. It was like, so I was, very much like, okay, I can hear all this, right? Like no confidentiality. Like, okay, now I know why I'm here, so that I didn't know much, but I was like, it's very Peace Corps-ish. Like, okay, let's figure this out. This doesn't seem right. Let's try
Can you tell us exactly what wasn't right with that?
Well, no confidentiality, and the fact that's going to help control HIV. But these people are sex workers. It's their job. Use condoms. That's the kind of thing we had at the moment. Make sure you're using condoms, which was easier said than done as a sex worker.
This is the push and pull of probably a lot of the work that you did, where there is the health of the human being with HIV, the clinical piece to it, but also the reality of the world that they live in and what they do and do not have control over in order for them to survive in that space, not just medically, but within their community.
Yeah. We call it that social determinants of health, which to me is what later, especially at USAID, I was focused on, how we look at other factors involved in people's lives that marginalize them. And there's an anecdote I tell, which to me was sort of the crux. It was a perfect example when I was at USAID, and that was I was in Uganda, in rural Uganda, in Mbale, and I was with a group of key populations, so sex workers and gay people and transgender and people who inject drugs. And we had peer educators, and I had this one young peer educator, and he was a gay man, and he was just distraught. He kept saying, I've ruined my friend's life, ruined his life. We had him tell the story, which was, I helped my friend test. My friend tested positive. My friend freaked out. He went home. He told his parents he was gay and he was HIV positive. And because of that, the parents kicked him out of the house. They wouldn't pay his school fees. So he's like, I've ruined his life. He has nowhere to live. He can't go to school. And I'm sitting with a colleague who said, wait, no, you saved his life. He's now on treatment. The work we did always was all about helping people know they were HIV positive and get them on treatment and retain them on treatment. And, here this young guy was like, what do you mean? No, I've ruined his life. And it was the counterbalance. It was perfect for me because yes, that young guy whose parents kicked him out of his house, his needs were housing, his needs were school fees, his needs were probably a boyfriend. And yet the thing we were giving him was a pill. You're positive and this will help you. And it was so frustrating, that counterbalance between those things. And that moment was perfect. Where I was like, what do you mean you've saved his life? And the young guy's like, I've ruined his life.
Well, and I think it gets down to this question of, well, what is the meaning of life? What makes your life rich? Yes, it's health. Yes, being able to function in the world in a healthy body is one thing, but also having your community, having your family, having livelihood, having all these different integral pieces that make your life rich beyond just your health.
Mm-hmm.
So you were just working with the meaning of life for your entire career.
Yeah.
Perfect. So you did Peace Corps and then you went and worked for the Ministry of Health in Thailand. Did you stay for quite a while or what was that transition?
Yeah, I was there for about 4 years, 5 years and 5. Yep. And then it was time to come back and get a master's degree. I went back to Minnesota and got a master's of public health, and then ended up in DC doing some domestic HIV work for about 10 years.
And where are we in the HIV epidemic timeline when
Yeah.
you got your
So
master's?
that was 94. So that was the beginning of alternative medications beyond DDI. There were other antiretrovirals, ARVs, that were coming out. And things were much more effective. We hadn't realized yet, though, that a lot of those ARVs prevent infection, right? We at that point thought it was really about helping people live longer. And so we had this classification where we watched your T cell, CD4, your white blood cell count. And if it went below a certain level, 200, we then put you on medication. Basically, you had to get sick to get the medication. We didn't realize that the medication actually helps prevent you from getting sick too. And it's always a mind blow to me, now 20, 30 years later, how different it is that you're test positive, you go on treatment right away.
Yeah, I think it's crazy that Malawi is the one who set the standard for just putting a person on treatment. Malawi, which is one of the poorest countries globally, and they said, we don't have the machines, the technology, the infrastructure to continue to test to see when people get sick. Because
Yep.
what was the turnaround time for tests for like 90 days? Like
Exactly.
a child could die in the 90-day period.
And we were waiting for them to get sick, right, to know these things. Like it was kind of, we didn't know a lot. And
Right.
that to me is such a piece of public health, things change. Science helps us understand, and we come up with guidance that may change. We don't really know, but we learn through research. We learn through lived realities of what works, what doesn't.
And we learn from others. It's not just America setting a standard, because Malawi set that standard and stuck to it, and everyone followed. So, but I am curious, what did you do in DC with the HIV epidemic? Because I don't think people know how severe it hit the DC area.
Yeah, I worked for a international organization, so I was doing more technical assistance work throughout the US, which included DC, but it was more with young LGBT young people.
And then what shifted you? Did you go from there to USAID or were there road stops?
I shipped off to South Africa with Advocates for Youth. That was the organization I worked for, and doing work with youth leaders in Botswana, South Africa, and Nigeria, and then shifted over to work around men and gender. And so how do we as men challenge gender norms? as an HIV strategy, but also as a gender-based violence strategy.
Can you explain why it's an HIV strategy?
Well, gender norms are linked to sexual behavior, and sort of this norm of the tough guy, the man. He can sleep with, have sex with any woman he wants, and so it sort of fed into the spread of HIV with different people having sex with different people. And so if we could look at that to say, well, that's actually really unhealthy behavior to have sex with all sorts of different people just to show you're a man. um, you know, and so, maybe we need to interrupt that. And the best way to interrupt that with men is other men telling them, don't do that. You don't have to be a man and rape women. Doesn't have to be that way, right? In fact, you have a sister, a mother, a daughter. Would you treat her that way? No. It was a really nice, social behavioral intervention with men to say men can stop rape. We go to the rally, Take Back the Night. It's a lot of women claiming they're taking the night back. They should. But where are the men to stand up and say, this? I'm a man. I don't rape people. Like, this is wrong, and challenge other men to do better and to embrace gender equality. It in fact improves their lives as well.
Which seems sort of revolutionary for the time, because when is this that you're working?
This is the 2000s. Yeah, so I was in South Africa 2003 to 2008, 2002 to 2008.
Because I feel like we still struggle with that now.
We still
And then how long were you in South Africa?
6 years.
Was there a moment in that period of time when you were working in South Africa that really sticks with you?
I think there were moments of working with some of these men who, working with military. I remember I was in Eswatini once doing a training, and I had a guy in the training, older man, and he was like, but it's African culture. It's my culture. I can't change. This is how men are. This is how men are supposed to be. And finally, one of the women stood up and said, okay, African man, you drive a Mercedes. That's German culture. You, where's your donkey? You African, go get your donkey and give me those keys. I'll drive your Mercedes. And her point being, stop using culture to defend your patriarchy, right? You're using it sometimes and then you're not. So it don't work that way, and you can change.
But I also think it's the people in the community have to stand up and say, okay, then go ride a donkey. Like, that woman was definitely needed in that conversation.
And it, happily, wonderfully shifted me away from doing these trainings to say, guys, do this yourselves. Here's some money. Let me become a donor to fund this stuff. You know what's best. You can convince these people much more than I can. Yeah.
What I'm also thinking about is when I met you, you were working at the Office of HIV/AIDS in key populations. And a lot of the work that I was aware of was focused on all the legislation coming out that was anti-LGBTQI.
Yeah. Mm-hmm.
And the networking that was needed to start thinking about, okay, how do we ensure that people get the care that they need and these policies that are incredibly harmful are stopped? Yeah.
I think one of the most powerful things was some work that the Georgetown University did at looking at countries that had decriminalized sex work, same-sex behavior, or allowed gender-affirming care. Their HIV rates were much lower than countries that had these restrictive laws. And it was excellent data to be able to advocate for, once again, this social determinant of health, having these punitive laws, criminalizing this behavior is not helping your HIV epidemic at all. And that was powerful. That we, in the end, we had a collaborative project with UNDP that PEPFAR was funding specifically on those laws and working with parliamentarians to say, we need to decriminalize some of this behavior. We need movements within each country to make this happen. It can't be a US imposed thing. We need folks to recognize same-sex behavior should not be criminalized. It's a colonial law. It's a law the British brought. Why do you still have this colonial law? Before that, you didn't criminalize this behavior. So, in fact, it makes your nation healthier if you decriminalize this behavior.
And were you seeing successful outcomes with that work?
Slowly. Botswana, Namibia, yay, after many, many years. And then some steps backwards, like Burundi, who actually didn't have a law and created one. Uganda continuing to finally pass this horrible legislation that was a punitive law against same-sex behavior. Going beyond just a law against same-sex behavior, it really criminalized being an activist it had a death sentence, which was later removed, but for repeat offenders, which was crazy, all sorts of things. It just really stigmatized the population that was already majorly stigmatized. It drove a lot of people away. It drove a lot of people underground, drove a lot of people away from life-saving treatment that they had in HIV at our drop-in centers. Not a helpful law.
So when you were at USAID, I don't know how you got there, but you eventually showed up.
I did.
And what was your role there, and how do you explain it to family and friends?
I think, so my role, I was a technical advisor. I always tell people, I worked with our country programs, our country missions, to make sure that their programming was state of the art, to make sure that they were truly investing wisely in the HIV epidemic control. And these populations, sex workers, gay men, trans folks, and drug users and prisoners, were vital. And we do have science that told us what is the best strategy to work with these folks.
How do you handle questions where people say, well, why do these people matter? Why do these key populations matter? Why can't we just forget them?
Yeah, I think I frame it in the science of public health, which is, but they're key drivers in the epidemic. And if we do not focus on them and create specific services for them, we are not going to control the epidemic. So you can either, have your moral judgment, or you can actually follow science. And the science says, no, it's vital that they're involved.
And then how would you explain how this affects America or Americans more directly?
Yeah. I, and I've done that a lot lately as I meet people who say, oh, wow, this is real. This USAID thing no longer exists. Wow, And yeah, I think a few things. I do believe the work we were doing was not just HIV, but it was health systems. And so I look at other, HIV included, but other communicable diseases like Ebola, which is a one that sort of people recognize and know. There are many others that I think we were helping to control. Monkeypox, Mpox, right, was spreading big time. I'm fearful that some of that will come back to the United States now. So I think that's part of it. But I think what I tell people is, the most wealthiest nation on earth as we are, yes, we have serious problems here, but the goodwill that came, the markets that came by the US being supportive, especially for LGBT folks, sex workers, like the support they had from US embassies was so incredible. It really did help save lives, and gave people hope. If you're a lesbian living in Uganda, it's really painful. You were born this way, and yet you're being left and right discriminated against. At least you had this beacon of the United States, along with some other European countries that were supportive of you, and that's all gone away. It's really painful to hear.
Are there specific communities that you think about now in particular where we've seen such drastic cuts to funding and specifically for key populations?
Yeah, I hear from them daily, and that was sort of uh, something I brought to USAID, which is I know a lot of our key pop communities, the leadership, a lot of the organizations who trust me, and I can encourage them, please take this money, it'll be really good for you. And then it all went away. And so now they're like, Kat, you told us to take this money and now it's not here. What are we supposed to do? It's been hard. I think the main thing, Leah, is just lack of access to treatment. And of course, you need to take this pill every day. And if you don't have that pill, you're going to die. And so you do hear stories of people not being able to access treatment these days. There's a lot of effort trying to get them into other systems to get their treatment, but a lot of people don't want to go to the main hospital where they're going to be discriminated against. They'd rather die than actually go there. So social media to me these days is just full of people who they've died, and people I don't know, but the leadership I know, and clearly these are young people. I'm sure they're dying from lack of access to treatment. So it's really painful to watch.
I mean, I'm just going to take a minute because it's incredibly painful seeing all the stories and talking with individuals about what that lack of treatment means, and it does mean the loss of life. Um, when you Here, though, well, let's start with this, because I think you touched upon a really important point, which is the trust that is built not only with the United States government, but the individuals created trusted partnerships with those organizations that had received the funding. They knew the nurses or the community health workers or the social service person that was providing the treatment. And so for that to break apart, it is much more detrimental because they're already in a space where they feel discriminated against. So having to now find new safe roads to get treatment, I can just imagine that's incredibly daunting.
Yeah. And, in some cases, those people are still there, right? They're not being funded by PEPFAR. So those allies, if you will, that, are still around. And that's what's saving most people, I think, these days is those relationships that were built. But in a lot of cases, they're not there anymore. Yeah. Or the access to it. We were supporting a lot of, we called them drop-in centers. So they were like community centers in communities throughout Africa and Asia. And most of them have shut down. And those centers, not only gave treatment, but they did STI treatment, they did psychosocial support, did all sorts of other things. So some of them still remain, but it's just the bulk of them have had to close because of our funding going away.
What are you concerned about now with the HIV epidemic, since we've seen, PEPFAR is still around, but it's a real step back in terms of the funding and the workforce? What are your concerns with how that will push the HIV virus to evolve, workforces to change, et cetera?
One of the really impressive things to me of PEPFAR and of public health in general, but PEPFAR especially, is how we were tracking progress. And we had the dashboards and we had every Friday reporting about all their activities, but that really gave us a lot of powerful data to say, we're really winning this epidemic. We're really, turning the tide. And my fear, I think one of the biggest struggles I have is I hope some of those structures are still there. I'm sure that a lot have gone away, but we're not even tracking success anymore. And so I'm fearful, when you stop treatment, that not only makes someone not healthy, it also increases their likelihood of transmitting HIV to others. And so I think, we were close, if not at epidemic control in some countries. Is that going to go away now because of this overnight cut of funding? I think what's really hard for me is to hear how this process of eliminating USAID has eliminated all this corruption. And that's so untrue.
Well, I think it comes down to it never really was about corruption
Hmm.
or the money, because the way in which other agencies in the US government are being funded right now, the fact that Argentina is getting, what, $40 billion, and USAID was $35 billion.
Yeah.
It wasn't that. I
Yeah.
also What do you think of the argument, though? I mean, it was all corrupt, so they just had to take it all down and then pick and choose and bring things back in place. Does that work?
I mean, the argument of what was being funded and key populations work, especially LGBT rights work, was a major how dare we fund these things, right? But sorry, at least in my work, there's a whole lot of science behind what we were funding. So you're not listening to the science. And I think what doesn't work is not listening to the science. That's a huge problem for us moving forward as a healthier nation, as a healthier world, that we're not following the science anymore.
When you talk about science, what in particular are you thinking?
How do you control an epidemic, an HIV epidemic? And it includes services for these key populations. It includes the laws, changing of the laws. Changing the laws helps reduce the spread of infection. When we move away from those services and away from championing those laws, it will only increase the spread of this virus.
And laws specifically around
Like
penalizing sexual behavior.
exactly criminalizing behavior, sex workers, same-sex behavior.
Are you seeing any areas of hope or rebuilding, or maybe even places where you find joy in the what's happening?
So right before I got on with you, I saw a friend post on his LinkedIn that he's hosting a seminar series called "AIDS is Dead, Thank God." And it's a debate discussion around the faulty premise that aid was set upon and how components of it really enriched wealthier people in these countries and not the poor. And it's maybe an opportunity for movements in this person is Kenya, but also working with folks in Indonesia. It's I think a time for a movement in these countries of self-determination, of the more country ownership for what they're doing, which is all language we were using at USAID. But there was this overlay of, the US government's interests in what we're funding. So that gives me a little hope to say, can folks do self-determination? It's painful to hear, to be part of, this is my dear, dear friend who's part of this panel. But I also think, are there different models? And another piece I had been working on at USAID, and I've continued to do a little work on, is social enterprise, is really helping these nonprofits, these NGOs set up small businesses to feed profit into the work they're doing. And so I'm hopeful because I see people starting to think a little differently about LGBT communities saying, well, okay, now we don't have this HIV money. It was always such a chore to take this money because it was one problem in our community, but it was the 17th problem. And the first one is housing. And maybe it's time we figure out other ways to fund ourselves to do this work that truly meets, like that, going to that story of that young guy in Uganda, it meets the needs, which is housing, which is school, versus a pill to make myself healthy. I'm hopeful that communities themselves can figure this out. And maybe donors, maybe there's more Mackenzie Scotts who, you don't know Mackenzie Scott as someone, there was Jeff Bezos' ex-wife who's giving away her $40 billion at little clumps of 10 million, 100 million at a time. It's very impressive. And it's once-off gifts to say, I like your mission, keep doing it. Some of these billionaires could do that more. And that if the U.S. government isn't taking their money from taxes, maybe this is the way they could help development as well. In her style, which is not telling you what to do. You just like what you do. Keep doing it.
If I'm seeing your long-term plan here, it is continue to work with local organizations who are thinking through how to make their space, their community stronger, healthier, and flourish. Have it be funded through philanthropy. And then maybe one day, as we move towards foreign assistance coming back, how would you want to see that integration, if it could even be integrated?
Yeah, I don't know, but for me, like always a detriment in this work was governments in some of these countries that were such a challenge, especially around key populations to work with. And so we'd have to figure out how that one could be better. And my champion or my call to a lot of my activist friends is in countries are like, would you go work for your government? Like I'm an activist and I ended up working at USAID. I said never would I, but I did, right? And I made change within government. And so I challenge you, go work for your government. Go make change in your government. If it's so bad, is there a way we could fix it from the inside as well as we're advocating on the outside?
And what is your call for Americans?
My call for Americans is, I think, understand the power of soft power. I think at USAID really tell that story very well, but I think you understand that helping the world as we were gave us tremendous leverage in terms of our economics and our power in the world. And so I think that to Americans, we are a giving people. We need to continue being a giving people. And I think that's what's most painful about this. We were giving. And if there are other ways to give, and if it's through nonprofits, if it's through churches, if it's through philanthropy, major donors, we need to continue to keep giving to the world because we have this wealth that we should be sharing.
And do you have a story about the importance of soft power where you saw it in real time?
I worked a lot with LGBT activists, and it's always painful when I hear countries like Ghana and Uganda and Kenya, we don't want this. This is a Western thing. And yet I sit there with my friends and colleagues who are Kenyan and Ghanaian and Ugandan, who are gay, who are lesbian, who are trans. And they're a sizable part of your population. And so I don't know, like they always were like this beacon that the US government brings is so helpful to us because the activists saying, so helpful to us in our advocacy with our own governments to be recognized, to be noticed. Right? So I don't know, that's part of it. It's soft power for a very small part of the population, which is LGBT folks. But they're very pro-American for that reason. They've less so now because of all these changes that have happened. But
what is the thing that worries you the most?
yeah, I think what worries me the most is this lack of access to treatment and the not only, morbidity that comes like of people being sicker, but also the spread of HIV, right? I think that's the biggest concern I have. I also think this shift towards away from the human rights of people, of LGBT rights. And that's something the US was helping to slow. That's huge because there's lots of countries where it's being used in Africa, especially against colonial masters. And one way we show the colonial masters we don't follow them is we don't believe in LGBT rights. And that's painful because I have lots of friends that are going to suffer because of that.
And are you seeing more momentum in that legislation?
I'm fearful it's coming. I'm not seeing it fully. Uganda's been at it for a while now, and they keep vacillating back and forth. They had this pressure from the World Bank and the U.S. government that if you go ahead and pass that law, we're gonna pull out a lot of financial support to you. And so that, but now that U.S. isn't that lever anymore to try to stop it. So who knows?
And what is one thing that you hope listeners take away from this podcast episode?
Yeah, I think I'm so glad you're doing this, Leah, because I think we didn't tell our story well enough. We really were doing pretty incredible work in very efficient ways. This budget, although it seems massive, really wasn't for the incredible amount of work we were doing. I feel lucky a way being in public health to show impact, to show how we really were almost at epidemic control in many countries is so incredible. So I think that's the message I'd like folks to hear, that, there's a lot of really amazing work happening, building a lot of goodwill towards America, and a lot of that has been taken away overnight.
Yeah. And I just love your central message too about epidemic control, not just being about a pill that stops the virus in the body, but the whole person and the community around that person to ensure that they're able to successfully take that pill through human rights work, policies. So if they can get their food, if they feel like they can trust the healthcare worker to talk about what's happening with their body, all of those things come together. And that's something that USA did. It was complex. It
Yep.
wasn't, I'm going to send you a bunch of medication, government A, and you will take it and distribute it out to your communities of need.
I need to be motivated. If I'm a sex worker, a very poor sex worker in Nigeria, how motivated am I, right? And this is giving me more than just a pill. It's motivating me to take that pill. Yep.
Yes. And also, I just go back to the story in Uganda where the gentleman was so sad that he had ruined his friend's life by having him learn that he was HIV positive. So if there wasn't a group there to come in and say, it's going to be okay.
Right. Well, and that situation specifically, like, it's very simple. Like, get a caseworker. First of all, get this guy housing for 3 months so he has somewhere to live, and then find a mother to go talk to his mother and say, take your son back. And you know what? That actually was working in Kenya. They were doing that, right? And we could pay for that, right? It wouldn't cost that much. And that gives that guy his house, his school fees, plus his pills, right? But we're just stuck on make sure he gets his pill.
All right. Well, Ken, this has been a really lovely conversation. Thanks for taking the time to talk with me.
Glad you're telling these stories because it needs to be told.
This is Leah. Thanks for joining me. If you enjoyed this episode, follow Global Development Interrupted wherever you get your podcast, and subscribe on Substack to get new stories and updates straight to your inbox.